Okay, guys, so then our second talk for the day is about hypersensitive pneumonitis. Maybe having a talk after that, maybe talking about ECMO is not the best idea, but I'll try to do my best. So this is kind of my outline. Talk about initial definition, epidemiology, pathophys. But our main focus is going to be clinical features and diagnostic criteria and studies for HP, and then just a little bit about treatment. So definition. So this is a definition made by the HP group. So there's a group that kind of devotes their time for studying. Most of the studies and review articles out there is from this group, and it's basically a pulmonary disease with respiratory symptoms resulting in dyspnea and cough from inhalation of an antigen in a previously sensitized individual. And this is also another group that have a lot of publications and review articles out there. It's from the National Heart and Lung and Blood Institute, and basically almost the same thing, immunologically induced inflammation of the lung parenchyma from inhalation of a known antigen causing HP. So when I initially been told I have to talk about HP, I was like, oh, what is HP? I don't know, and how am I gonna talk an hour about it? But then as I was reading more, I learned that there's a lot of people don't know a lot about HP, and there's a lot of areas for research out there. So this is the title of the review article. The title of the review article says that we need more research in HP. So you know that there's not a lot of information out there. So in terms of epidemiology, this is looked at the incidence rate of interstitial lung disease in New Mexico, and it was about 30 in 100,000, and HP was about 1.5% in the incidence in those cases. And this is in New Mexico, so it's more of a dry climate, so we can't generalize, of course. We think in a more humid climate, the incidence rate will actually be higher. Another population-based cohort in the UK found the incidence rate of AP was about 1 to 100,000. This is an old study in '93 in France, looking at patient with farmer lungs, type of HP, and shows that people about age of 40 and above there's a higher rate or prevalence of HP in that group, and very importantly, people who are smokers have a significantly reduced risk of developing HP. Very important. Unfortunately, the pointer is not working, but right here, about 0.4% prevalence, significant in smokers, and in non-smokers about 1.6%. And of course, geography also plays an important role. So they looked into different climates in France. So looked into regular plains and higher altitude, and they found it's also worse in higher altitude. And they think it's of course because of increased humidity and more rain, and that can predispose to people having HP. And it's usually less in drier climates. So the pathogenesis, so it's a two-hit hypothesis. So we're saying in a patient who is, or a person who is genetically predisposed into developing HP, that with the combination of being exposed to the actual antigen will lead to someone to have HP. So this, I promise, is the most boring slide I have. So basically, you have exposure to the antigen, whatever it is, and I'll go into detail for that later on, in a patient who's genetically susceptible, and then what you have is increased response from a T helper 1 and T helper 2 cells, which leads to influx of lymphocytes, and that can eventually lead to tissue damage and fibrosis. You also will have IgG and antigen immunocomplex formation that kind of goes and activates complement cascades, activates macrophages, release chemoattractants, and that can release, and the neutrophils will release enzymes that can cause tissue damage as well. So I think what, especially the people who are taking the boards, need to understand that it's a combination of type 3 and type 4 hypersensitivity reaction that leads to HP. So that's something that can come on the board. So this is the key points, and I want to focus on initially about clinical features, but we're going to talk about all the other things: antigens, imaging, PFT findings, antibody testing, inhalation challenge, and BAL, and histopathology. To write that down. So I want to start with the case. So this is an actual patient that we saw in clinic, and I want to kind of dissect the case, and hopefully that helps kind of understand the different diagnostic studies that are out there. So there's a 53-year-old male, presents to the clinic with shortness of breath going on for 6 years, getting progressively worse. He was saying that eventually was not able to complete workplace health assessment tests, which occurs annually. He also complains of cough, which is dry, occurring for the past year. He does mention there was weight loss, about 40 pounds, was intentional. He initially thought it was because of his weight, that's why he short of breath, lost 40 pounds, no effect. And then denies wheezing and fevers. No significant history that's really relevant, just GERD, Barrett's, hyperlipidemia, and depression. So key points about clinical features. This looks into the major cohorts we have. We have the HP study again, which I'll be talking about a lot during this talk, and Mayo Clinic, which look at all their HP patients, and found that dyspnea and cough, very common, to be expected, and flu-like symptoms, chest discomfort, and in terms of physical exam, crackle and wheezing, and some clubbing as well. You might be present. Again, these are very non-specific, so but these are some of the common features that they might present with or will present with. So back to our patient and looking at his social history. So as non-smoker, very important, like I said, non-smokers usually have actually increased risk. Occasional alcohol use, no drug use. He lives in a condo for the past 15 years. He has a new furnace, humidifier placed or installed recently. No non-construction work, mold or water exposure, or water damage exposure, and he works as a general manager, retired for 15 years, and he had a pool, I think, on the top floor. No gardening, no pets, and then again, he does have a hot tub in the house, located indoors, which he drains every 3 months, located on lower level, more humidity there. So this is kind of his social history. Now, it's very important in HP. I could look if there's a study that actually looks into that, but usually you can't really get that social history or his occupational history from the first office visit. It usually takes a digging into the history and after looking at all the studies and suspecting it, and then the patient might remember. So it really will need a lot of work from the. So history is very important, and usually can't get all the history from the first office visit. So now we'll talk about antigens involved. So these are some of the major antigens. So birds' proteins are very common. You got pigeon, dove, ducks, and parakeets. You've got bacteria, and in terms of farmer's lung, which we might hear a lot about, there's actually very specific bacteria for that. Saccharopolyspora rectivirala, something like that. Anyway, close enough, but they're very common for farmer's lungs. And then you've got also myobacterium. So, for example, hot tub lungs, that's myobacterium avium. If you got metal workers, they have myobacterium. So non-tuberculous myobacterium immunogenum, I think it's called. So these are the most common ones. Of course, there's a lot out there. So I'm just putting this slide in to show that there's a lot of antigens out there, and they can call all the, and then they have all these funny names as well associated with them. Okay. Let's go back. So these are some of the villains that can cause it. You got those. Okay, you got parakeets. So you got parrots. You got even lovebirds. So they might look innocent and cute, but they can kill you. Okay. So
you kill you.
So physical exam. So basically, just vitals are normal, and the only abnormal finding was that he has crackles heard bilaterally and the posterior lower lobes. No wheezing, and otherwise the rest of his exam is normal. So this is back to our patients, of course. So this is predictors of HP. So again, the HP group came up with a very nice study looking at, they were trying to see if there's anything out there that might predict the possibility of having HP, and they look at their whole cohort and look back and did a lot of regression analysis, and they found that exposure to a known offending antigen increases your odds significantly, so 38 or 30, almost 39, very significant. You've got positive precipitating antibodies, which I'll talk about later on even more, recurrent episodes of symptoms, inspiratory crackle, symptoms 48 hours after exposure, and weight loss. So these all increases your odds. Of course, exposure to a known antigen is very important as well. And then they came up with this probability table, which actually has been validated. So very few stuff out there have been validated. This is actually one of them. So and been proven out that actually works. So you can look here and see someone who, for example, comes in with the exposure to a known offending agent and recurrent episodes of symptoms, that with the combination of, for example, crackles and serum precipitant, which is positive, will have an 81% chance of having hypersensitivity pneumonitis. So that would put HP higher in your differential. But when someone comes in, for example, with symptoms 48 hours after exposure, weight loss, crackles, let's say he has crackles and a negative serum precipitant, that would drop him to about 8%. So that lowers, kind of lowers your puts the HP lower in your differential. So like I said, this actually has been validated. So now a lot of things have been validated out there, works. So I think that should be, of course, incorporated, I think, into our practice. So back to our patients. So these, come to a history physical, and then, of course, we have our PFTs. And shows that he has a normal FEV1 to FVC ratio, a low FVC, and a low total lung capacity, suggestive of restriction, and then low DLCO or diffusion capacity of 45%. And it's a good study. So in terms of PFT findings, so of course, PFT is not sensitive or specific for HP. I think that's pretty straightforward. But what you typical picture would be similar to a picture that we have with our patient, which is you'll have a restrictive pattern with a low diffusion capacity. But in some cases, like Farman lungs, which we might have more prevalence of smoking, they might have emphysema, and an obstructive defect might actually be present. And in the HP, so there's talk out there that everyone who has hypersensitivity pneumonitis will have a low diffusion capacity, but that's not always the case. Not common, but not always the case. 38 patients out of 177, again in the HP study, had a normal diffusion. Okay, so X-ray. So maybe one of the second or third years might want to take a crack at this. No, I'm kidding. So, so here is a patient, X-ray of our patient that shows some increased interstitial markings and some nodules as well that's present. You can, thank you. So this is his lateral view as well. So in terms of imaging studies, X-rays are pretty useless. I'm sorry, I should not have said that. But so the yield from the X-ray is pretty low. So maybe in chronic HP, you might have some findings, but usually in acute, you might not really. Most of the times it will be normal. And there's a lot of studies out there that kind of looked into. So there's one study that kind of looked into 11 patients with HP, and only one of them had an abnormal X-ray. So it more likely to rule out other pathology. And what you might see in an X-ray, so you see nodular opacities that might be present, sparing of the apices and bases, which I'll talk more about later on, and some interstitial reticular changes as well. Consolidation is very rare. So this is where I think a lot of the HP kind of blew up after the introduction of the HRCT, so it helped a lot in the diagnosis of HP. And so you'll find some acute changes and some chronic changes. So in acute, you'll have diffuse ground glass opacities, mostly in the center. So you see centrilobular ground glass, and I think that's very pathognomonic for HP. And air trapping as well. In terms of chronic, you'll have some reticulation, you'll have some interstitial thickening, honeycombing, air trapping, of course, centrilobular ground glass opacity. So that's very important. So I think in the boards, if they have a case of HP and bring images, they'll definitely mention that. So this is not of our patient. This is just some CT scans I was able to find. So you'll see here bilateral ground glass changes, and you can sees more of a centrilobular appearance or located. And this is another one here on your left. You'll see some patchy ground glass changes, and then for the same patients 3 years later, you'll see some increase in, so you see some traction bronchiectasis there, again diffuse ground glass, and you also see some interstitial changes as well. Again, another CT showing the same thing, so ground glass, more centrilobular in appearance. This is more of a chronic HP picture, so you can see honeycombing. So these are from different patients. You can see on the left there's significant honeycombing, more in the upper lobes than the lower, so it usually spares the bases. And you can see here on the right, you can see some ground glass changes, interstitial changes, and some air trapping as well. And this is just a picture to show you that it usually spares the bases. That's a more common picture that you'll see on a CT scan. It's more middle and upper lobes. So this is actually a pretty nice study that was done, that was published in Radiology 2008, and they kind of look into the difference between, trying to see based on radiology if you can differentiate NSIP, IPF, and hypersensitivity pneumonitis. So what they did is actually took patients with diagnosis of all those three conditions, and they were so the diagnosis of all those three conditions, and they were diagnosed basically on pathology. So they had surgical lung biopsy and also by clinical history. And then what they did is they did two board-certified pathologists, sorry, not pathologists, but radiologists, and they told them to basically look at the CT scans and tell them what their diagnosis would be, and see if that correlates with the actual diagnosis. So this is what they found. So in terms of, sensitivity was low, specificity was actually higher and decent for all three, for HP, IPF, and NSIP. But if I want to focus on the positive predictive value. So positive predictive value means if they said that they have HP, then the likelihood they have HP is, for example here, 70%. So 70% of the time they got it right for HP. In IPF it was 84, and in NSIP was 90. So pretty decent. Of course, it's not. For it to be kind of gold standard, it should be up into high 90s. So obviously not the gold standard, but it's pretty decent in terms of looking at specific findings. And this is actually what they found in terms of differences. So all three of them, of course, had reticulation, very significant. All of them had ground glass changes. HP had more ground glass than others. HP and NSIP. Now, centrilobular nodules was much more common, 56% in HP rather than the other two conditions. So in terms of honeycombing, you got more honeycombing in IPF and the bases, of course, so that's very important. So HP usually does not involve the bases as much. Of course, that's not always the case, but in the common findings, it does not involve the bases. Again, relative sparing of the lung bases, HP, of course, had 39%. And there's significant air trapping more than others as well. So I think what you need to focus on, especially for people taking the boards, is that centrilobular ground glass opacities and sparing of the bases are very kind of pathognomonic for. If they're going to push for HP in the boards, that's what they're going to probably be saying. So now we go into the serum-specific antibodies. So this is what we do at Henry Ford. So if you want to check for antibodies, you type in hypersensitivity pneumonitis in EPIC, and it pops up. They need about 2 mLs or 3, at least, or preferably 3 cc's of blood. You send it to Valencia, California, and there they run it, I think, 3 days a week. So you should get the results usually about a week or so. So that's what we do here. And it's basically a double diffusion immunoassay. And what they do is they have this piece of gel, and they make holes in them. And then what they do is they put the antibody, or the antigen, I should say, that they have, and then, of course, a little bit drop of serum. And then what happens is that they incubate it for 48 hours. And then what happens is that they kind of start precipitating outside. And if the antibody and antigen do bind together, they will start forming an immune complex. They will precipitate, and then they form like a line. And that can be seen. So it looks like something like this. So you'll have your antigens outside, and then you got your serum in, so the middle hole inside. And what you see is that if you incubate it, I don't know if it shows pretty well, but there is a line or a circle that goes right around. So you can see here that the line is so what happens is that when the antibody and antigen precipitate, they form a line right here. So you can see that this antigen reacted with the serum, this as well, but not so much these, as you can see that the circle does not complete. So that's how it kind of looks like. And that's what we do. Of course, there are other ways to check for this. There are some people who use ELISA, but in Henry Ford, we use this, or something similar to this. And this is kind of what you will get in EPIC. So it tells you, so these are just a reference range, and this is the antigen that we actually check. So we don't check everything, as I told you, the list is extensive, but this is what we kind of check for. And in our patient, it came back positive. It came back positive for, so the reds, whatever reds positive, these are kind of mildly positive, but pigeon droppings was significantly positive in his cases. But he had no exposure for pigeon droppings or exposure to pigeons at all. So going back, so how does this come into our talk? So in terms of, so you can have, so it doesn't kind of rule it in or rule it out. So you can have a lot of asymptomatic farmers, 10% of them might have a positive antibody. 40% of actual pigeon breeders might have a positive antibody. So, and of course, a negative result does not mean that you don't have HP. So it's kind of putting it all together. But the HP group, as I mentioned in that table, the serum precipitin actually had a major role in, or had increased the odds ratio of you developing HP. So now we're going to talk about the inhalation challenge. So inhalation challenge is basically taking a patient who you suspect has HP and you know what the antigen might be, and expose them to that antigen and see what happens. So if he becomes more symptomatic within the next 8 to 12 hours, and they also look at pulmonary function tests and there's a drop in the FVC, then that kind of signifies a positive result. So that's kind of what it is. It's not used. It's not part of our studies that we use. The reason why is it lacks standardization, and of course we don't know what the criteria for a positive response is. So it needs more research. So it's not something that we use or incorporate in our practice as of yet. It's mostly used in kind of in research settings, but we need more information and more standardization for this to actually be incorporated into our clinical practice. So talking about BAL, so what you will see in a BAL, you'll see BAL lymphocytosis. So greater than 30% in non-smokers and 20% in current smokers. And in the hypersensitivity, in the cohort, the HP group cohort, actually 24 of the 199 patients did not have any lymphocytosis, but obviously it's not very common. Usually patients with HP will have significant lymphocytosis, usually more than 50% and higher. Again, asymptomatic exposed individuals can also have an increase in lymphocytosis in their BAL as well. So again, it helps you, but it's actually not, of course, it's not gold standard. Of course, a lot of things can cause lymphocytosis too, as we all know. So now I know there's talk about the CD4 to CD8 ratio in the BAL. So in hypersensitivity pneumonitis, the concept is that the ratio will be low. So you have more CD8, so you have a CD4 to CD8 ratio that is actually less than 1. That's what you technically HP should look at. But in actual practice, a lot goes into this. So there's the different types of HP, like different antigen can create a different ratio. Smokers will have a higher ratio as well. And usually people with, or patients with acute HP might have a low CD4 to CD8 ratio, but chronic HP might even have a higher CD4 to CD8 ratio. So it doesn't really help them that much, and it's actually recommended not to even check it. Yeah, so I know and so more recent review articles that I've been reading so actually don't even recommend checking it anymore.
So there's studies on that show why it wasn't recommended?
What?
They studied BALs and find that the ratio was not correlated to HP.
I'm not sure there's a study looking specifically into that, but there are a lot of cases out there that shows, for example, smokers had a significant higher CD4-CD8 ratio, and definitely chronic HP will have a higher ratio. And patients, I think, patients who are exposed to pigeons, I think, have also a higher ratio. So I think because of that, they're recommending not to do so. One more thing. So that's about that. And the main reason why the CD4-CD8 ratio is because they want to differentiate between sarcoidosis as well, which can sometimes look like HP, and the ratio is usually higher in sarcoid patients. So this is our patient. So 182 WBCs and significant lymphocytosis, 71% in his case. So now talk about last part, the histopathology. So So in acute changes, you'll have neutrophil and insoluble infiltration in the alveoli and some small vessel vasculitis. You'll have diffuse alveolar damage, and of course, based on the pathophysiology that I talked about, you'll have immunoglobulins and complement deposition in the vessels as well, to be expected. Now, again, in the acute, now these I think are important, especially for patients who are, for people who are taking the boards, because I think it's very pathognomonic for HP, and if they want to make you think about HP, these are the wordings I think they're going to tell you. So they're going to say lymphocyte predominant interstitial changes or infiltrates, poorly formed non-necrotizing granulomas. So that's very important. So poorly formed non-necrotizing granulomas, and they will try to because if it's well formed, that usually they'll go with sarcoidosis. So that's how kind of differentiate the two together. So it's going to be poorly formed, and you'll have peribronchial fibrosis in association with isolated giant cells. So giant cells is also important. So this is how it looks like. So this is a piece of lung, and if you go to a little bit high power field, and you see you see lymphocytosis there, a lot of lymphocytes that are present. And on H&E stain, you can definitely see that significant lymphocytosis. And in terms, so just trust me when I say this is a granuloma. So it's a poorly formed granuloma. So this is, I guess, how it's supposed to look like. And you see some lymphocytosis as well here on the left. And in the right, you can see again two poorly formed granulomas on the right, on B right there. When we zoom in, you can see here a granuloma, and inside you can see some giant cells as well. And I have another picture of giant cells so you can actually look at a better picture. And on the right, bottom right, you'll have again another poorly formed granuloma with class-related giant cells too. So these are what giant cells should look like on pathology. So very clear, you can see 3 of them right there, and there's arrows right next to them. Okay, so now chronic. So chronic can be, that's where I think problems arise, because chronics can have different patterns. So you have like NSIP-like pattern, UIP, organized pneumonia pattern, and you've got centrilobular fibrosis, peribronchial fibrosis, and bridging fibrosis. So I think, again, from my reading, the most pathognomonic for HP is the centrilobular fibrosis, peribronchial fibrosis, of course, and the bridging fibrosis. Or those, if they bring them up in the boards again, those are the, I think, wording that they're going to use. So this is what you will see. So this is peribronchial fibrosis on H&E stain. So there's fibrosis here on either side of the bronchial. Next one. Do you have anything else to add?
Well, the other thing we see here is also you see a lot of adaptocellular lymphocytes. So the lymphocyte is still there. So then that's what's driving the fibrosis. And that's why it's centrilobular. It's very irritable.
Okay. So I think, again, for boards, centrilobular changes, giant cells, and I think poorly formed granulomas, I think those are very important to know going in, looking into HP.
What is the difference when you're looking at poorly formed?
Well, I think that's the point Lana was trying to make. The granulomas are sarcoid. Are these epithelial, what we call them epithelial granulomas? They're tight granulomas, they're big. There's not a lot of lymphocyte infiltrate around them. Versus these they're certainly granulomas, and as opposed to compared to sarcoid, which literally are like these big balls of pale cells, whereas these are more vague. Actually, the ones that showed are pretty good granulomas, but a lot of times you just see one multinuclear giant cell here and there. You really have to search for it. The other thing when they differentiate is some infection, which is some granulomas, and those generally you start getting aggregates the histopathology and the sites in the body. So that's a necrotizing granuloma. Can you get those in sarcoid? Yeah. You get them in HP.
Okay. So now I'm trying to put it all together. So I mentioned all these tests and studies that you can do and what you might see. but what is gold standard? How do you make this diagnosis? So what's the diagnostic criteria for HP? How do you make that diagnosis comfortably? So question is, it's mostly, there's nothing out there that kind of have a great diagnosis. So these are 4 studies that was done, and you can see the most recent ones was 97. That was pretty old. Actually, this one from 97 is what up-to-date code. So even up-to-date is not really up-to-date. But so these are diagnostic criteria that were made, and they were never validated. So I mean, I'm not sure if anyone's experienced in using these, but they're not really well validated. They're there. They said this is what we think and go from there, but they're not really well studied. So in terms of, so that's, I think, brings me back to this slide here by the HP group. So I think this probability ratio or table here, kind of, which has been validated before and works, kind of gives you an idea of, when you think HP is actually, when you think the diagnosis is HP or not. And then that, with incorporating it to your other features, then that would suggest that you would order other studies and go forward and really put HP as high in your differential. So this is kind of again another so this is from a review article from Dr. Selman. Was recent. The review article was recent from 2012, and Dr. Selman is one of the pioneers in HP. Most of the articles that I've been reading, he has some sort of involvement in them. And basically, of course, if you have someone with clinical findings of ILD, who has significant HRCT with typical findings, again, a positive antibody test and significant lymphocytosis, then you can maybe, and with a good story, it's very important to have a very good story. I think that's where the most important thing is going to lead you to HP. Then you can diagnose HP. Now, if you're not sure, or none of the tests that you've ordered kind of points towards HP, and it doesn't show the really classic findings, and I think that's when you kind of go and order a surgical lung biopsy to see exactly what's going on and what you might see. Yes, Dr. Morris.
My question here, since your BAL normally takes a few days to come back, once you got a scope down there, you're doing a basic procedure on a patient under anesthesia, why wouldn't you just want to go ahead and do transbronchial biopsies along with the BAL? You have to avoid the biopsy, get your answer on the biopsy, on the transbronchials.
Yeah, so that's a great point. So, I had a question about, what best approaches to get the biopsy, or is it the transbronchial or get a surgical biopsy to increase your yield? And I couldn't really find an answer to that, but that's actually a great point. If you suspect it, then you might as well just do a biopsy at that time too.
Can I write that in the chat, actually? Chad, what's the incidence? If we send you transbronchial tissue,
can it be done on a transbronchial biopsy? And the answer is exactly yes. There's 4, let's say, think of HP as 4 major histologic features. One is that you have peribronchial and peri-airway inflammation. Second is you have that inflammation extends into the alveolar parenchyma. Third, you have a complex injury pattern. And fourth, you have these vague granulomas. Okay, that's the 4-legged chair. Okay? Studies have shown that even in patients that clinically high on the differential is HP, that on a wedge biopsy, you may only see all 4 features in only about 70% of the cases. So, and that's a lot bigger area covered than a transbronchial biopsy. But we have made this diagnosis on a transbronchial, at least suggested that that's what we favor. And then we throw it back in your court and say, if you're thinking HP, I'm thinking HP, and let's chase that down. And usually it's because there's significant peri-airway inflammation and maybe a complex injury pattern as well. And that's probably the most common pattern of 2 legs of the chair that I've seen. The granulomas, unless it's a really rip-roaring textbook word type photo, the granulomas are usually sort of few and far between. They're usually not like they have in the photos, the books and on tests and stuff like that. They're usually a lot harder to find. So that leg is is probably not going to be picked up on a transplant biopsy, but I agree, since you're down the whole anyways. I mean, I don't do this for a living, I'm not a real doctor, I play one on TV. But, yeah, well, run up to a biopsy, and then you could say, well, it looks like HP, we're thinking HP, you're thinking HP, the lymphocyte count is high. It's a lot, as opposed to sample.
Okay. So
Is there a differential, like if somebody with those same findings, and the clinician is right in there, at 40% certain of the diagnosis, is that biopsy going to offer you other differential?
Well, in the cellular phase of NSIP, you get a lymphocytic infiltrate, and it can be in the alveolar parenchyma, but it also can be perineal. In sarcoid, you can get a less pronounced lymphocytic infiltrate within the parenchyma and the alveolar. No one's really figured that one out. But generally, the reason like transplant biopsy or antibody biopsy for sarcoid is the granulomas follow the lymphatic channels. Okay, so wherever you have lymphatics in the lung, you're going to find granulomas, and then you're picking that up from the transplant bronchial biopsy. Okay, but that would be like a differential, and I've had cases where there was more lymphocytes than you really expect to see in the granular sarcoid. I don't see any granulomas. That's really the main finding there. And the differential given to me by you guys is sarcoid versus HP. And then at that point I said, well, I don't see granulomas, of course, one way or the other. And the granulomas can look significantly different between the two diseases. But you can get the same kind of granulomas that Alani showed here in sarcoid. If it was real easy to get, surgeons would do it. He knows I'm kidding.
So again, there's no clear-cut diagnostic criteria out there. I think it's just putting it all together. And I think the most important thing is, history. You get a good history for HP, then I think you can go ahead and order the rest of the studies. I guess in some of the cases you're going to order the studies anyway because you can look at not just HP with HRCT. You can look at all different ILDs that you might be suspecting. But again, it really is, I think, in the history, and I think Dr. Jennings the other day mentioned that during a biopsy of one of his patients, it has NSIP, but based on the history, diagnosis was they diagnosed him with HP appropriately. So I think that's mainly what you kind of have to really go into. So this is a classification. Now I didn't really touch about classification. Most of the review articles that I talked about actually always talk about the classifications, but I think it's really hard in actual clinical practice, it's really hard to differentiate them, so that's why I'm not talking a lot about them. So there's acute, of course, so this is after an acute exposure, 48 hours after exposure, you get fever, malaise, and dyspnea. I get normal chest X, as I mentioned previously, and maybe some ground glass changes on the CT scan. And I think the problem comes with the subacute, because subacute can sometimes present with findings in acute, or sometimes present finding that looks like chronic. So I think that's really hard to really label patient as having subacute changes or falling to the subacute category. So it's usually gradual repeated exposure, again, the cough and dyspnea, weight loss. You can see on X-ray some micronodules, and in CT you see the centrilobular ground glassifiers I was talking about before. And of course in chronic is usually where you see the fibrosis on the X-ray and the honeycombing on the HRCT as well. So those are class. I just brought it in so if they bring it to the boards. But all the review articles that I was reading about kind of are shying away from this classification. So treatment. So this is my only slide on treatment. So antigen avoidance is, I guess, what you can do. There are some cases that they will improve, of course. And not progress if they're not exposed to the antigen. Some people who have been significantly exposed can still, even after antigen withdrawal or avoidance, can still even progress after that. So something to keep in mind. But I mean, there's been, case series and some studies out there regarding steroids, but nothing really concrete. So even the use of steroids is, I can't really give a recommendations about using steroids and when. There's not really good evidence out there. So it's basically just antigen avoidance and making sure that you get the right diagnosis, not missing anything else. Okay, it's my references. And
One other point, I don't know if you saw the article in Chest, I think it was just this past month, in refractory cases of hypersensitive pneumonitis. Over the years, many of us tried things like, azathioprine, methotrexate, never ever worked on anybody. There was an article saying that they had success with mycophenolate. In the chronic cases, they had about a half dozen cases or so. They're describing in that, so just to throw that just was published recently here in the past month.
Yeah, did not come across it, but thank you, Dr. Morris. Any further questions, guys?
So because when we're being taught that HP could have air trapping on HRCT, how relevant is that in swaying your diagnosis? And also the head cheese appearance on HRCT, because they always mention that. Is that just a teaching point, or is it something that you really, you see some nodules and you see some air trapping, you say it's probably HP?
Remember we had that one where the kind of biopsy like the very strong individual and then she's kind of like symptoms. So, but you don't see that all the time. But you see it's kind of specific, or it's bizarre.
Yeah. So air trap. You see it more common, but you can see it in other cases as well. So in this, for example, this study, 75% of the HP group, they had air trapping seen on their on imaging studies. Well, in IPF and NSIP, it was much less. So I would not say that if you see air trapping, that means you make your diagnosis, of course. So, but definitely suggestive. Thank you.